Well, thank you, everyone. Again, we're having our next webinar on the series latest highlights in neurosurgical oncology. And today we have a very special speaker, Dr. Susan Chang, on adult IDH Wildtype Glioma update. And as a brief introduction, Dr. Chang is a professor in the Division of Neuro-Oncology and specializes in treating adults with brain tumors. She's a co-leader of the Neuro-Oncology program for the Helen Diller Family Comprehensive Cancer Center. And she has a major research focus on the development of novel therapies for patients and has served on the PI on numerous trials. She's a leader of the multi-programmatic brand, including the NIH SPORE and the program project brands that address the integration of physiologic and metabolic imaging with genomic biomarker to optimize treatment of patients with primary brain tumors. She is also the editor-in-chief for Neuro-Oncology, which is one of our strongest journals. And Dr. Chang is the director of the Neuro-Oncology Supportive Care Services and has created novel supportive care programs such as the Gordon Murray Neuro-Oncology Caregiver Program and the Sherry Sobrato Brain Tumor Survivorship Program, both developed to enhance the care and quality of patients and families. And with that in mind, I really appreciate you coming and Dr. Costas Hajapanais for supporting this effort. And please go ahead and I'm happy to do your lecture.
Well, thank you very much, Yoshio, and for all of the invited organizers who've invited me to do this. I really appreciate it, and it's really great to be part of the tumor section. So this is a talk on adult IDH Wildtype Glioma. It's an update. So I do not have any disclosures. So for the outline, what I thought I would do is review the 2021 updated glioma classification, because this has significant implications in how we identify patients with glioma in the adult population, but also it's critical for in terms of deciding about treatment. And then we'll talk a little bit about what the standard treatments are, and then the challenges for treating these tumors and why the clinical trial strategies are really geared to address these types of challenges. And I think you'll be impressed with the diverse aspects of how we are trying to make a difference in the outcome of our patients with glioblastoma. So I want to start with a classic case. I think that everyone who sees this type of a patient and with the imaging characteristics of a contrast-enhancing centrally necrotic scan, biopsies showing the classic histological features, I think this is not something anybody would be surprised that it is a glioblastoma. But more and more, we are seeing patients like this, and this is another case of a relatively young patient who presented with seizures. And this patient has a non-enhancing mass in the left mesial temporal lobe. And you can see that the pathology shows on histology anyway that there's relatively low cellularity, and it's sort of a bland aspect of it. And why is this important? Well, it really speaks to the 2021 classification of adult glioma. This is the updated one. And it really speaks to the integration of all of the genetic and information that we use that incorporates things like the mutation in the isocitrate dehydrogenase gene. And this is critical for patients with adults with glioma, because as you know, the first decision about these types of tumors is whether there is an IDH mutation or not. And that is a huge difference in how we've classified tumors in the past, as opposed to histological grade. When we look at the cells and we look at the whether there is microvascular proliferation or cellular necrosis, those are the things that we typically in the past have emphasized. But now with this integration of the diagnosis using these types of next generation sequencing and methylation profiling, we now have a diagnosis of glioblastoma that is an IDH wild type, but they could also have other things such as EGFR amplification, TERT promoter mutation, and copy number alteration in 7 and 10 chromosomes. So the definition of glioblastoma in 2021, I think it's more important to understand what is not a glioblastoma anymore. So any IDH mutant glioma, even if it's histologically a grade 4, is not considered a glioblastoma. So we used to call those secondary glioblastoma in the past. So that term doesn't exist anymore. This is IDH wild type or IDH mutant. If the tumor has an H3K27 or G34 mutation, then those are not considered glioblastoma either. And any pediatric glioma really is not as well. So for this case that I presented, the second case, the patient with the non-enhancing left mesial temporal lobe, when we did the UCSF 500 sequencing results, you can see that there are pathogenic abnormalities, trisomy 7, monosomy 10, CDKN2A and CDKN2B homozygous deletion, TERT promoter mutation, NF homozygous deletion, and PTEN abnormality as well. And so even with the histologic features and with the imaging characteristics that look more like a low-grade glioma, the molecular integrated diagnosis for this patient based on the World Health Organization 2021 classification is glioblastoma IDH wild type, CNS grade 4. So why is this important? Well, there's several reasons, because the prognostic value of IDH mutation has been seen in the context of tumor grade. So for example, here what you see are histologies that look like grade 3 or grade 4, but look at the difference in the survival based on whether there's a mutation in the IDH gene or whether it's wild type. So you can see that how you would counsel a patient based on this is going to be critical. And we've sort of looked at this in a more global fashion at UCSF, where this publication by David Solomon in 2022, where there's a cohort of patients that have what we think are what we consider sort of molecular GBM. And you can see that those patients with the molecular features of glioblastoma IDH wild type, that their survival follows the classic IDH wild type patients. So this is important in terms of understanding the prognosis of the patients. So the implications, as I mentioned, for this is very important in terms of characterizing the tumor and their biology, the integration of the molecular and genomic features to improve our diagnosis, to provide reliable information on clinical outcome and facilitating how we decide about management for our patients, but most importantly, to allow the enrollment of these patients with a uniform diagnosis into clinical trials so we can better assess the efficacy. So this patient, patient number 2, would actually be eligible for glioblastoma clinical trials. The treatment paradigm for newly diagnosed IDH wild-type glioma in adults, unfortunately, has not changed significantly. I think that everyone is aware of the STOOP regimen for patients using concurrent and adjuvant temozolomide with 6 weeks of radiation therapy, the use of tumor treating fields. These are all standard treatments. And there's some differences if patients have MGMT methylation or unmethylation status. But in general, these are the standard treatments that are offered for patients with glioblastoma. We point out, of course, that maximal safe resection is the first decision-making point when we see a patient with this type of tumor. And consensus guidelines internationally have really supported maximal safe extent of resection, and I'm sort of focusing on this because of the audience. But as you can see here, both the SNO and IANO guidelines do recommend maximal safe resection. And why this is important is because over time, we have previously, focused on the contrast enhancing volume as the area of concern and the area to measure when we are thinking of patients enrolled in clinical trials and also for prognosis. But the extent of involvement of the tumor is now characterized by both the contrast enhancing and the non-enhancing tumor volume as well. And this is some of the work done by Annette Molinaro, Harvey Jumper, and the team at UCSF, as well as other groups at Mayo and Ohio, where they looked at whether the amount of residual non-enhancing volume actually had an impact on survival. And you can see here that both in the test group and the validation group, that the patients who did the best were those who had residual non-enhancing postoperative volume of less than 5.4 mils. So this is something that, I think talks about what we think about as not only the contrast enhancing volume, but the tumor volume really, which encompasses the non-enhancing disease, since we know that these tumors are infiltrative. And this was subsequently validated in the RANO RESEC group, and this is an international group of investigators who looked at this information and tried to classify patients again based on whether those patients had residual contrast enhancing, but also non-enhancing disease. And you can see here the difference for what's called a supramaximal contrast enhancing resection, where you go beyond the contrast enhancement compared to less. So what they did was, of all of these patients, they identified 356 patients with wild-type glioblastoma who had a complete contrast-enhancing disease resection, and then looked at whether the volume of non-contrast enhancement, whether that had an impact. And this is the results. And so when we think about patients being enrolled into clinical trials, because this has such a great effect on the prognosis, it's very important that we think about stratification for whether patients have had a maximal contrast enhancement, which is class 1, versus the other classes, because this has such an impact on survival. So it's just something to be aware of in terms of when we think about extent of resection and volume of residual contrast enhancing and non-enhancing disease for patients enrolled in clinical trials. So as we know, there are many surgical adjuncts to minimize adverse effects, use of mapping and other techniques that I'm not going to go into. But what's interesting is also the intraoperative techniques to enhance tumor detection. And I think we're all aware of the use of 5-ALA, neuronavigation, intraoperative MRI, and so forth. But I think what's exciting is the use of Raman spectroscopy that is really emerging to identify not only different subgroups of tumors, but more recently by the group here, you can see using this to have a fast label-free detection of glioma infiltration at the time of doing surgery. So this is something that encompasses artificial intelligence, as well as really interesting ways to look at simulated Raman histology integrated into the workflow of the surgical resection as well. Now, we all know that these tumors are very resistant. They're refractory to treatment, unfortunately recur. And once the tumor recurs, the individual treatment decision can be very variable. It can include more radiation, more surgery, chemotherapy, use of bevacizumab, as well as TTF, and also, of course, clinical trials and palliative care. I point to this paper in Nature Medicine in 2023 because of the move to ensure that serial tissue sampling is part of our sort of standard of when we see a patient with recurrent disease. And there are many reasons why that is the case, because many times it is very difficult to discern tumor progression from pseudoprogression. There are many non-invasive metabolic imaging and PET imaging to try to address this. But I think also the information that we gain from serial tissue sampling is important because we know that these tumors evolve with time. So because we have tissue at the time of initial diagnosis, using that information to guide what you want to treat the patient with at the time of progression may not be appropriate. And so when we think about the treatment paradigm for recurrent wild-type glioma, again, you can see here where the surgical debulk is indicated, and then clinical trials becomes, I think, of paramount importance, just as in terms of newly diagnosed as well, but certainly at a time of recurrence. And then the RANO RESEC group has also looked at the prognostic evaluation of re-resection in recurrent glioblastoma. And this is, again, where your surgical decision-making is important in terms of, how much disease can you safely remove, and does this make sense for that patient? Always keeping in mind, I think, that you don't want to cause any further neurological decline. So when we think about the current landscape for what is approved for patients with high-grade glioma, you can see that there is really a paucity of advances that we've made. Lomustine, carmustine is back in the 1970s. The gliadel wafer, 2003. Temozolomide, as you all know, 2005. And then subsequently, use of bevacizumab, which really is for recurrent glioblastoma, approved based, as you can see here, on the totality of data, not because of overall survival benefit. And then TTF. So what are the challenges in terms of why is it so difficult to treat these patients with IDH wildtype glioblastoma? And I think we all are aware of the many challenges that we face with this disease. Of course, the drug delivery across the blood-brain barrier, the fact that these patients have multiple pathways that are abnormally mutated, for example, aberrant mutations in signaling pathways. The immunosuppressive environment is also a major barrier, and tumor heterogeneity. So a lot of work that's been done shows that even within the same patient, if you sample multiple areas within the same patient, you can have differences in the genetic profile of these tumors. So even within the same patient, there's this heterogeneity of the disease. So the strategies, when we look at the updates now in terms of clinical trials that are being pursued, really address these types of challenges. And the first, I think, is how do we improve the delivery of agents across the blood-brain barrier? And it's exciting that there are a number of technologies that are being used to try to address this. And then for precision medicine, in terms of targeting some unique aspects of tumor biology and metabolism, is another area of a lot of changes. How we move forward with immunotherapy approaches is also interesting. And then we all, I think, agree that probably one approach is probably not going to be enough. So the combination strategies is another aspect that's being tested in many clinical trials. So in terms of the surgically based strategies, I think you're all aware of such things as the laser interstitial thermal therapy, direct injection of either viruses, drugs, or cells now, convection-enhanced delivery using a pressure gradient across to get drugs into the tissue itself, use of reservoirs and intra-arterial delivery are all ways to enhance the distribution of agent directly into the tumor and try to spare systemic effects. Photodynamic therapy is also being pursued using 5-ALA, not only for visualization, but for treatment as well. And then I think what has really increased tremendously over the years has been the use of interventional neuro-oncology program, where focused ultrasound, for example, is being tested in multiple trials, looking at whether we can use low-intensity ultrasound with microbubbles to temporarily disrupt the blood-brain barrier, and to then be able to deliver drugs across the blood-brain barrier during that period of time. And so there are many different ways of trying to do this using focused ultrasound, and many agents that are being used as well. Intra-arterial delivery of agents is also being pursued. Obviously, in that case, the technical aspect of it is very important, as well as the potential side effects. So all of these are currently being tested, and will be very interesting to see if the result of using strategies such as focused ultrasound will result in an improved efficacy. It has been, many years now that we've identified the different pathways that are altered in glioblastoma, according to the TCGA's analysis, which was done in 2013. But as a result of that, we know that there are many targeted therapies, and this is already probably very outdated in terms of the types of drugs that are used to target these agents. But what is very exciting is the way in which we target these treatments and how we study it using these adaptive randomization designs. And so GBM Agile is one example of the type of ways that we understand their specific targets and what the agents are being used. And because you can do this with concurrent arms, there is an efficiency of getting this information Also, because you have one control arm as well, it does allow for these studies to be done. The hope is that it's done in a much more efficient manner where you have a signal that is received regarding the efficacy to decide which arm should be continued on in a larger phase 2 or phase 3 trial. And it's interesting that paxilicib is actually going to be studied in a phase 3 study as a result of this being evaluated in the GBM Agile. I'm just going to touch a little bit about gene therapy for glioblastoma. This is something that, I think we've explored for many, many years now, and it's a very interesting, but using viral vectors designed to target and produce tumoricidal effects in glioblastoma. But as with any new treatment, there are many challenges. And I think for gene therapy in general, just how we deliver the viral vectors, the transgene transfection percentage, how much of it do you actually get into the tumor? What about the immunosuppressive environment for which you're giving this treatment? And what are some of the side effects that could happen because of the response of the host to these foreign proteins? So those are some of the challenges. In addition to using viruses to deliver these types of genetic therapies, there are also many non-viral approaches being explored, for example, nanoparticles, liposomes, and micelles. And then when we think about immunotherapy, there are so many diverse targets for immunotherapy that's appropriate to be evaluating. But unfortunately, to date, there is really no survival advantage to use of checkpoint inhibitors, something that's been shown to be very effective in other solid cancers like melanoma and lung cancer. And then for tumors that we know have microsatellite instability, we can use a checkpoint inhibitor in that particular subgrouping of tumors. Oncolytic viral therapy for glioblastoma. I remember many years ago when Dr. Wilson was the chair, we did the first HSV trial with this. But this is where we use genetically modified recombinant replication competent viruses to enhance the specificity and cytotoxicity. So modified HSV and polioviruses are being used. What's important to note is that there is an FDA approval of this strategy in metastatic melanoma. And you may also be aware that in Japan, there is an HSV oncolytic viral therapy that's approved for malignant glioma. In addition to the fact that these tumors are lysed because of the infection of the virus, there is also the additional anti-tumoral effects from the release of specific tumor antigens that can have an immunotherapeutic value. And so there are many ongoing trials, and you can see here, I put Dr. Kyokas and Dr. Markert, very prominent members of the tumor section who have ongoing studies using this particular strategy. I think what is exciting and new in the last few years has really been the use of living cell therapeutics. This is where we modify, we take cells out from the patient, we modify it genetically and expand it, and then reinfuse this back into the patient. This is the chimeric antigen receptor T cell therapy. You may all be aware it's approved for hematological malignancies, and now the question is, will this be also something of value in solid cancers, including glioblastoma? Important to note, there are many other cellular therapy approaches. So CAR T is just one type of cell. There are certainly dendritic cells, stem cells, NK cells, macrophages that are being used to try to see if we can actually hone in onto the immune system and have an anti-tumor effect using this strategy. And what's exciting is that just in the last year, for example, you can see here, there have been 3 publications on CAR T trials in recurrent glioblastoma. And these are all targeting EGFR-V3, EGFR itself, IL-13. So understanding the biology of the disease and sort of tailoring your treatment to it is also very important. It's also interesting to see the delivery of these agents, how they're being done. It's either by intracranial, intravenous, intraventricular, intrathecal, intracavitary. So there are many different approaches to these types of therapies, and it will be, hopefully these will translate in the larger, more advanced studies into some signal of efficacy. The challenges are huge. This is a very nice review in 2024 in Cells. But you can see here that as of today, so I searched this today, there are 24 actively recruiting CAR T trials with or without immune modulation in glioma, in patients with glioma. So very exciting, very novel approach. And as I mentioned, it is quite involved because you are taking cells out from the patient, modulating them, and then putting back in. So even the treatment itself can be a little bit challenging. But if this results in an effective effect on the tumor, then I think that this is something that we're all very excited about. And then lastly, you may be aware of the interaction of the neurons now. So cancer neuroscience, there are so many important interactions between the nervous system and cancer. So in the past, we used to think that the cancer existed in the brain and the neurons were just sitting around. But we now know that there are actual interactions between the neurons, active signaling that's happening, electrical activity that's happening between the neurons and the cancer cells that can have an effect. And this can be quite broad-reaching, not only locally within the brain, but even the contralateral hemisphere. And we're learning more about these paracrine neural cancer interactions, systemic neural cancer interactions, and obviously how cancer therapy might affect the nervous system. So with all of this, this is a really outstanding review article by Dr. Winkler's group, just published in January this year, Cancer Discovery. So I'll point that to you for further reference. So in summary, I think it's important to understand the molecular subgroups of glioma to more accurately predict prognosis and to guide personal care when you see a patient in the clinic, for example, making sure that we understand what the integrated diagnosis is. I always, it's important, this multidisciplinary individualized approach at the time of diagnosis and recurrence is so important. And having a team that really keeps the patient at the center where we can really advise as to what the best strategy is, both at the time of diagnosis and recurrence. All of the diverse clinical trials evaluating strategies are really to overcome the challenges related to tumor heterogeneity, immunosuppression, the microenvironment, and how do we more effectively deliver drugs to overcome the blood-brain barrier. But ultimately, all of this work will need to be continued to understand the biology of IDH Wildtype Glioma, and how we translate that to bridge these discoveries to the clinic is really the way that we will have success. So I just want to thank you again for giving me the opportunity to speak with you today. I know it was a lot to cover in a few minutes, but I also wanted to acknowledge my great team here at UCSF, truly multidisciplinary. You can see now how many tumor neurosurgeons we have. I'm counting them, 9, almost 10, but also the radiation oncologists, the pathologists, and the neuroradiologists in our team. So thank you very much for your attention. I'm happy to take a few questions.
Thank you so much, Dr. Chang. If anybody has any questions, please post them on the chat. And if anybody from the moderators want to ask any questions, please feel free.
Well, since we have such an expert, I might ask a couple of questions if you don't mind.
Sure.
Thank you. That was fantastic. I really enjoyed it. I wondered, in your own hands, have you seen differences as how patients based on age? Because we know that the T cell population changes with age, and maybe the immunotherapy might actually work better in some of our older patients. Have you seen any anecdotal things that would point us to that so far?
Yeah, I think the studies are really too early right now to tell. We've started a CAR T therapy, Dr. Okada and Jenny Clark in our group here, targeting EGFRV3. But it's a phase 1. And so, we have a limited number of patients so far enrolled. So I think it's going to take time for us to understand better the impact on age. And it's really immunological status, because you could have an older patient that could have a relatively robust immune system and similarly younger patients. So I think it's going to be interesting to look at the correlative studies that are so important with these trials, right? What the sort of biomarkers that might predict which patients are going to do well as a result of these strategies. So I think there's a lot still to learn.
In that, sorry, one follow-up
Yeah.
question. In that study for your CAR T cells, do you have a dexamethasone washout period or any other things that you want to wash out prior to giving your CAR Ts?
Yeah, there's a minimum amount of steroids that you want on board, and making sure because of the immunosuppressive effect.
Thank you so much.
Oh, you're welcome.
I think you're muted, Ashish. Perhaps just mention, obviously, GBM as a whole is the percentage of cases is low, and the number of patients that go into clinical trials is very limited. So we really have to be conscious on taking any opportunity that we have to offer clinical trials, regardless if we have any our institution, or try to route patients to clinical trials, because that's the only opportunity that we have to advance the field, which hasn't had major breakthroughs. So I don't know if you have any comments on that for other centers and how to join consortiums or clinical trials to facilitate offering these novel therapies.
No, I think that's an important consideration. Giving the patients the opportunity to participate in clinical trials is important. I think the cooperative groups, the Alliance and the NRG, are both really great ways to get involved from your institutional point of view, if you're not already part of those groups. And remember, if you are part of Alliance, you actually have access to the NRG trials as well, because there is a network, a clinical trial network that you can be part of. And so being able to have those opportunities for patients is really important. The Brain Tumor Network, which is sponsored by the Sontag Foundation, actually has a mechanism by which they help patients find the right clinical trials. I think that's always a challenge, right? When patients saying, well, what trial might I be eligible for? And sometimes it can be very challenging to understand, what are the criteria that's needed for these patients to participate in trials, especially at the time of recurrence as well. So being able to triage and manage those kinds of questions is really important as well.
I don't know if people saw the question that was in the chat. I would love to hear your answer. I've read some papers about it, about the genetic mutations of V3, and also how it changes over time. It seems like it decreases with time from the papers that I have read. But I don't know how you would like to answer that question.
Yeah, I think this speaks to the challenge of tumor heterogeneity, and the approach that we're taking, because there was a study done, there have been studies now targeting EGFRvIII just as the target. The approach that Dr. Okada is taking is where there's a prime and a kill. So you prime the tumor based on this marker, but then you use a different marker to kill. And this way you're just sort of attracting the cells to the environment, and then once the cells are there, then they can have a more global effect. So there are many different strategies that are trying to do that as well.
And then there's another question as well. I don't know if you see this as well.
About the landscape of knowledge of
yep.
GBM management in rural settings like sub-Saharan Africa. Well, I think if the areas don't have access to things like the next generation sequencing, I think that's where the IHC for at least IDH mutation is helpful. So hopefully at least that's a point, because that is the sort of first decision that you make, whether these tumors are IDH mutant or IDH wild type. And because you do have the IHC ability, that hopefully your neuropathologists, even in rural settings, might have access to that type of testing. They may not have testing to look at all of the other gene abnormalities, but at least that would give you some insight into that. Yeah, so I think the World Health Organization, because it is World Health Organization, they try to address how do you make diagnoses based on access to the various technologies to make the diagnosis.
So I had a question. My Zoom was messed up. So great talk. I really enjoyed it. and what a breadth of, just covering everything. I guess, from a neurosurgeon perspective, delivery of agents into the tumor microenvironment is always kind of puzzled me. We have trials where we're doing intratumoral delivery of viruses. But then, in DIPG, they're giving, convection they're giving like, intraventricular CAR Ts. And I'm just curious, which do you think, if you had to put your money on it, which would be the best way to deliver, in the tumor bed, or in the CSF, or you think, IV? I guess, like, I just don't. I think they're getting different. We're getting different results on different trials. So I'm just kind of curious what you think.
Yeah, I think when you think of delivery, the first thing you have to think of, what is the agent and how
Right.
does it work, right? So that's the first question,
Right.
because how you deliver it is going to matter. The reason why intratumoral injection of, say, oncolytic viruses makes sense is because once the virus gets in, this is the hope, right? The virus gets in, it infects the cells, it lyses the cells, it releases further viruses. So there's sort of a cascade effect. I think the idea that you would make a cavity and try to inject into a cavity and think that that drug or agent is going to get into the infiltrative part of the disease, into the parenchyma of the brain, probably is why a lot of intracavitary may not work very well, right? And this is why convection enhanced delivery was sort of looked upon as a way to, deliver drugs using a pressure gradient rather than a concentration gradient into the tissues, using that sort of pressure effect and being able to distribute drug more effectively to a larger volume in the brain. I think for the CAR T, these are cells. So again, you have to think about the agent. If the agent has to get in, then how is it best? And I think the CSF is being used because it's the proximity to the area of interest, right? And you can't really. I know there's convection enhanced delivery within the brainstem, for example, that's been done by Russ Lanza and his group to try to get drugs into it. But you're limited by volume, you're limited by side effects, you're limited by just the structural aspect and the dynamics of being able to do that safely. So I think it's the question really, you have to step back and say, well, what is it we're trying to deliver? What is the mechanism of action before you sort of think about what's the best way to deliver?
Absolutely. Thanks. Yeah. Sorry, broad question.
No, it's fine. It's good because it makes you think, right? That it's not just a one size fit all for anything. It's got to be tailored to the agent that you're thinking of delivering.
I appreciate it.
Yeah. Costas, I see you there.
Yeah,
Hey.
Susan,
Good to see
and
you.
really thank you for this wonderful webinar. We've learned so much from you through the years and the challenges of managing malignant brain tumors and some of the opportunities. So I really appreciate this talk today, and I learned some new things, and I think our viewers were also quite pleased with it too. These webinars are really a nice opportunity for us all to get together, and I'm really thankful for our panelists here who put it together with Joshua, Ashish, Ankush, and Kristen. So thank you very much on behalf of the tumor section.
Absolutely.
Thank you so much, and please stay tuned for the next one in 2 weeks. And I really appreciate and hope we see each other soon. Thank you, everyone.
Thanks again for the invitation. It was great to
Absolutely.
meet
Thank
you
you
all.
very much.
Bye.
Bye.